Actually, when we planned this symposia, we would like to present the data that was used for the registrational trial when the documents applied during the last year to the Ministry of Health. But later on, we decided to change a little bit the program and to show to you the interim analysis of early access program in Russia. Why we think that it's much more important than to show you just the registrational trial? Because I call this study, when the final analysis will be done, it could be called a Russian Kupik. Because in this trial, only F3, F4 patient was enrolled. And this is very important for you, because actually, when these drugs will be widely used in this country, the primary patients that you will be treated with these drugs will be definitely patients who relapsed after the double therapy and the patients who badly needed to be cured. This is the F3 and F4 patients. And so if we look at the inclusion and exclusion criteria, what is it should be what are the patients were enrolled? These are ages, genotype 1, no co-infection with HBV and HCV, have severe fibrosis, F3 or cirrhosis, F4. But in the distinguish of Kupik, because in those time when this study was started, the Kupik data, the preliminary data was already published, and it was restricted but only compensated very mild cirrhosis. And this is definitely will explain the results that we get from this trial. This is also was a strict rules for the neutrophils count, for hemoglobin level, and there's no contraindication to administration of both medication. So that's the most complicated cases there were excluded, or the possible early failure of this kind of treatment were excluded just before the beginning of the trial according to the inclusion and exclusion criteria. What is the design of the study? Multi-center, open-label, early access program. This is a part of a worldwide study, the big one. And in the world, they planned to be recruited 1,900 patients from all over the country. But we have showed to you the first 61 patients who were recruited to this analysis and complete the treatment. So this is a first 61 patients. Actually, the early access program was finished at the moment when the drug was approved by Ministry of Health. But still we have not data for some patients who continued treatment or not achieved their SVR 24 weeks date. So that some patient is still on the way. We also use the futility rules that universally accepted. You know, there are many presenters already talk about this, and so I not to stop on it and not to spare the time for that. Here is a list of the centers. You can see that's a truly multi-center. You can see that this is our colleagues, Professor Zhdanov Clinic, Professor Pasechnikov Clinic, many clinics from Moscow, also from Tyumen, also from Samara. So that's a really multi-center for Russia. Practically all the regions they were represented in this trial. This is a typical protocol. I also don't spare time for that because you see that's two subtypes of patient: treatment naive or relapsers with F3, F4, or the patients who were null responders or have the severe fibrosis like F4. So this is a little bit difference between only this is could be response guided therapy, and this is a therapy that always have the 48 weeks in all patients in this subgroup. This is a battery again. I could not. Could you please next slide? Doesn't work. Yeah. This is baseline characteristics according to the protocol. You see that only 26% of patients were treatment naive. The very huge proportion was the null responders. 36% was the null responders. Next slide. This is the demographics. As you can see already from yesterday, this is a little bit difference from the experience that we have in European countries, in the Q-peak, for example. Our patient is younger. The mean age is 44 years. Even yesterday when we showed the trial with boceprevir, you also noticed that the mean age was younger than 50. But this is a range of years. This is predominantly male, 66%. All of them, except one patient, was white. The body mass index was 27. Next slide, please. And this is very interesting because the majority of patients, and because most of them, they were null responders, they have very high viral load. 62% have viral load more than 800,000 international units per mil. Some patients were really cirrhotic with alpha-fetoprotein more than 50 nanograms per mil. Fibrosis assessment, bridging fibrosis 59%, F4 41%. As in many other studies, they're predominantly genotype 1b, 95%. Only 2 patients among 61, they harbored the genotype 1a. And for IL-28 genotype, you see this reflects the accessibility to these types of the study. Missing or unknown. Unfortunately, because it's an early access program, it's not financed centrally, and the local hospital, they do themselves. And you can see 97%, they do not perform their IL-28 genotypes. So this is a point that we can resolve in our country to make an access to this very important analysis for triple therapy. Next slide, please. Initial dose of ribavirin. This is also very important because sometimes patients, especially F4, they need lower starting dose of ribavirin. But if you look at that, there were no patients who started with a dose of 800. Most of the patients started with a normal dose, 1,200 or 1,000 or even 1,400, because the dose of ribavirin were recalculated in this early access trial for the body weight or body mass. Here you can see that's how it's calculated the mean dose, and that you see in the majority of patients the dose was located between 10 to 15, and even in 1/3 between 15 and 20. So in some patients, dose of ribavirin is even higher than recommended of 15.5 milligram per kilogram per day. Next slide, please. This is also very interesting in how many patients we reduce the dose. This is a ribavirin dose reduced in percent dependent from the initial dose. Interestingly, the patients who received the highest dose of riba, no one can reduce it. The majority of patients who need the reduction of ribavirin dose, 50%, started with a lower dosage. Does it mean that they at the baseline, they have low hemoglobin level? So you started with a lower dose, and in these patients, more often you need to reduce the riba dose during the treatment. Next slide. How many patients discontinue treatment? This is a very important point, because as you remember the Q-peak data, a lot of patients can discontinue all drugs. But in this interim analysis, majority of patients, 84%, completed 12 weeks therapy with tenofovir PEG and riba. This is a very, very good result, especially for F4, F3 patients. There are some patients that are different, that trial terminated totally, no one. Some patients complete tenofovir, but then they need to dose reduction of PEG-riba in 3%. They discontinue tenofovir, but continue PEG-riba and riba, PEG interferon and riba, 8%. They also discontinue tenofovir and PEG interferon and riba, that's 5% only. Next slide. This is also interesting. You listened to the lecture of Professor Laurent Castera just a few hours ago, and you can see, because there was no the strict rules, because it's an early access program, but not the phase 3 trial, so there were options. What method for detecting or evaluating fibrosis was used? And you can see that it's good that in Russia we used in 79% we use fibroscan for staging the patient for F3 and F4. 16% of patient was biopsied just before the entering of early access program, and only 5% use fibrosis marker. Actually, you know that the combination of these two methods is much more useful. But I think that for the future, it's quite increased the proportion that in which we use the two kind of serological markers. Next slide, please. So the efficacy result. Next slide. This is a average ICV RNA viral load decline, and you can see that during the first 4 weeks it was a huge decline in the viral load, because you know this kind of triple therapy, they have no lead-in phase, so all three drugs started together, and you can see that from the beginning the very, very high antiviral effect, and then after the week 4 there's a second slope with a quite low decline. What does it mean? If you remember the slides that Professor Berg showed, you noted that the result at the first 4-week treatment, it's practically identical to the SVR if you apply it for the patients with F4. This is very important. Next slide. How it looks in the figures. This is the first group, treatment naive and treatment relapsers. There were 30 patients, and this is week 4. Combined detectable and undetectable, below 25 international units per mil. And you can see that in 83% HCV RNA was undetectable, and in 90% it was below 25 international units per mil. In a very small proportion of patients it was detectable but below this level. Non-responder and the viral breakthrough patients, 31. This is a quite different results. Yes, HCV RNA undetectable only in 52%, and below 25 in 87%. But I remind you that this is a week 4, but the treatment with triple therapy continues until week 12. Next slide. And this is a week 12 results. Not surprising that practically all patients, 93%, HCV RNA was undetectable at week 12. In second group, non-responders plus viral breakthrough, 94, below 25 international units per mil, and 87% HCV RNA undetectable. Next slide, please. Next slide. Safety result. Next slide. We analyzed the whole population. We analyzed not only the adverse events, but also analyzed using the erythropoietin. It's very important for such kind of patient with F3 and 4. Next slide, please. How we grading the anemia in this trial? You can see the hemoglobin levels. It's classified like grade 1, grade 2, grade 3, and grade 4. And you can see that grade 4 is below 70. Next slide. Next slide, the last point that we have data up to date, this is week 16. So there's patients, all the patients, they are achieve week 12. And by safety result, we have the week 16 data for all these population 61 patients. Yes, of course, the treatment comforted 24 weeks in the RGT group and to week 48 in the non-responders and F4 group. But I think that by the end of this year, we can show you the full data for the week 24 and the week 48. But still, we have the week 16 results. Erythropoietin use all types was used in 18% of patients. Granulocyte colony stimulating factors in 3%. Platelets transfusion in 1 patient. Iron-based drugs in 1 patient. Whole blood transfusion, no 1. Plasma and albumin, there were no transfused. Next slide, please. Here it is summarizing the grade 1-4 adverse events considered treatment-related by at least 5% of patients. So you can see that practically all subjects have 1 or more adverse event. It's not surprising that the most dominating side effect was anemia, 55%, pruritus, 24%, and the rash, 23%. Actually, the thrombocytopenia and neutropenia, this is very, very interesting, because you know that yesterday we showed you the week 8 analysis with boceprevir, and it was very high rate of neutropenia. But in this trial, you can see that only 5% patients demonstrated the neutropenia with a grade 1 or 4 in this study. Next slide, please. The grade 2 and 4 adverse events, more severe, that reported by at least 3% of patients. Here you can see the same distribution, the most prevalent anemia, then thrombocytopenia, rash, and neutropenia again is only in 3% of patients. Next slide. Most severe, grade 3-4 adverse events, that reported at least 2% of patients. This is every third patient have grade 3 and 4 adverse events, and again, the first and the most prevalent, this was an anemia. Every third patient experienced anemia of grade 3 and 4. And thrombocytopenia was noted in such advanced grade only in 3% of patients. Next slide, please. Next slide. This is very interesting. How many patients stopped telaprevir due to adverse events? If you can see, this is only 7 patients discontinued telaprevir among the 61. So it's 11%. Due to what they stopped it? Actually, from the previous studies, we have the impression that mainly cause of the stopping therapy in telaprevir-treated patient, it's skin lesions, it's a rash. No. In this study, the anemia was the most prevalent cause of stopping telaprevir. The second one was thrombocytopenia. So for the patients with F3 and F4, not skin lesions cause the stopping their treatment with telaprevir, but anemia and thrombocytopenia. Next slide. So this is a percentage of the grades of this adverse event, anemia and rash, and you can see that you should much more aware of anemia than for rash, because no one patient demonstrated rash of grade 3 or 4 that really need to be hardly treated or need to consider the discontinuation of telaprevir. Majority have the grade 1, that it's easily treated with topical steroids, and the 10% have grade 2, that also can be controlled by topical corticosteroids, but also you need to add the consulting of dermatologist just to correct the dose and the ointment for the treatment of these skin lesions. But anemia, you see that the grade 3 and 4, every third patient demonstrate this adverse event. Next slide. This is anemia and rash adverse event by grade and discontinuation. And you can see, again, rash only grade 1 and 2, and anemia half and half, grade 3 and 4. This is the main problem that caused the stopping the telaprevir in this interim analysis of the Russian early access program. Next slide. In conclusion, ladies and gentlemen, by this interim analysis that included 61 patients from the Russian early access program for the patients with F3, F4, 62% has baseline HCV RNA level more than 800,000 international units per mil, so they have high viral load. 41 had F4, and 59% of patients had F3, grade of fibrosis. Half of the patients was prior partial responders, null responders, or viral breakthrough. As a safety results, every third patient developed grade 3 or grade 4 anemia, and 7% of them discontinued treatment with telaprevir. No one developed grade 3 or 4 rash, and no one discontinued the telaprevir due to rash. 7% developed anemia as a serious adverse event, but no one patient developed rash as serious adverse event. And the efficacy result by intention to treat analysis, 67% of patients were undetectable HCV RNA at week 4, and this is a patient, they are candidate to have the same percentage as an SVR. It is quite good for liver cirrhosis and advanced fibrosis. 67% have the undetectable at weeks 4 and 12. This is the same. And 90% have undetectable at week 12. This is a patients, the proportion between 67 and 90%. This is a proportion for which we should be a little bit cautious, because they can give them relapses after completing the course of 24 weeks or 48 weeks full course of pegylated interferon